Hey, I think we're gonna start. Welcome everybody. Welcome back. We got a great program for the rest of the year. Julie had, I think, 2 sessions in the time I was away. But we're going to continue on with this series, hopefully every week or so, or second week, and bring diverse topics in neonatology. And today it is my pleasure to introduce again Arvind Sehgal. He is a professor in neonatology and head of the cardiovascular research at Monash in Melbourne, in Australia. And he's been doing many years of work looking at the cardiovascular adaptations after preterm birth in the last years. Also has a strong focus on looking at the effect of fetal growth restrictions and small for gestational age infants. So today he's going to take us to his work and his understandings and concepts within this field. Arvind, over to you.
Thanks very much, Kurt. I just want to check again the slides and the video is
I
working
can see
okay.
them. Yeah, all working.
All right. Look, thank you for the invitation and delighted to be back. So this is part 2 of my lecture on fetal growth restriction. And essentially, I will only going to be touching a little bit upon the heart part, but I'm really going to talk more about the arteries. And some of this work we will be presenting at the Monash Cardiovascular Symposium. So anybody in the audience would like to attend online or face-to-face, please take a snapshot, screenshot, and use the barcode to scan and register. So the work I present today has almost a decade of vascular ultrasound behind it, and some of the work is with my collaborators in Spain and in the UK. So hope you will take something from it and put into practice, and also if you are in a field of public health, then something might come of it as well. So I'll be talking a little bit about hypertension, how it is just the clinical tip of the iceberg, then really go into vascular ultrasound, what we know from the ultrasound done in fetuses, how placenta gives some information about what is going wrong with the vasculature even before birth, some epidemiologic data, mechanistic links in terms of what is behind the changes we see in the arteries. As I mentioned, I won't be talking so much about the heart today, which I did in the first part some months back, but really talking about how the systemic arteries and the pulmonary arteries are affected. And certainly, time permitting, talk a little bit about therapeutics and interventions, how we can make a difference. So there are a number of definitions in the literature about fetal growth restriction. For this presentation purpose and all my research, I've used this definition as birth weight less than 10 centile for gestation in sex and with antenatal Doppler abnormalities. So what is seen in the heart? We know that echocardiography in newborns reveals very similar features which have been seen by fetal ultrasounds. And conventional echo has shown dilated heart, hypertrophies, diastolic dysfunction, and also systolic dysfunction. And some of our own work using the spectral tracking echocardiography has also shown very early on that the systolic and diastolic function is affected. And the beauty of this technology is that it can tell you which part of the heart is more affected. So the basal segments are more affected as the orientation of fibers make them more susceptible to chronic hypoxia. We also know that biochemical evidence exists. If you take cord blood, do serum samples of troponin in growth restricted deliveries, then those levels are significantly higher versus similar gestation but well-grown baby. So there is wealth of data available. And it's not an isolated thing. There is, as you say, intermingling mechanistic links. The heart is affected in terms of architecture. But my focus today is mainly on the structure of the arteries and the tone of the arteries and how they impact the heart in terms of increasing myocardial workload and generate dysfunction. If you look at the original paper from David Barker about fetal origins of adult hypertension, it talks a little bit about changes in blood vessel compliance and changes in vascular structure. So that was 1992, and we have come fair distance, but not much work in terms of this population and trying to find out what exactly is wrong with the vessels and what's the scientific evidence behind this epidemiologic linkage between growth restriction and adult hypertension. So that somehow hasn't been looked at in detail. So this is our first work. We published it some time back. This is internationally collaborative work where we talk about fetal growth restriction and hypertension in the offspring. What are the links and what can we do about that in terms of therapies? So there are multiple links, as I mentioned earlier. I'll be talking about early vascular aging. So essentially giving you information to show that the arteries, systemic arteries, especially in the newborn period belonging to growth restricted infants, are their dynamic properties are very similar to someone who could be 70-year-old today. The relevance of major artery biomechanics, you'd be surprised to know, goes back to 1877, where they looked at pulse wave velocities, much before our clinical concept that hypertension is a thing. And certainly hypertension is common, leading cause of death amongst all cardiovascular risk factors and affecting millions of adults in the United States and many more around the world. So the issue is that the arterial biomechanics in growth restricted cohorts are affected not in the adult life, but from the fetal life. And because I work in neonates, you can pick up those changes in preterm newborns. Those changes persist in childhood and adulthood, young adults as well. So there is a heap of data which is cross-sectional that people have looked at these cohorts intermittently at different age groups, but also a good amount of data where they have been followed longitudinally, and you can see that these changes tend to persist for much longer. Birth weight has a major impact on how blood pressure evolves and how the vascular stiffness contributes to pulse pressure and peripheral vascular resistance. So clinical construct, we know that this cohort is at increased risk of perinatal death. We also know that this cohort is at increased risk of adult onset cardiovascular disease. And how common it is worldwide, 5 to 15%, more so in premature infants, and Australia-wide, the data is somewhere in the middle to say, okay, 9 to 10% of the births are affected. So it's an issue which is of major public health concern, but not so much intervention or follow-up somehow is being focused on this cohort. So I mentioned about the data across age groups. So systematic reviews, you can see meta-analysis of data. You can see there is inverse association between low birth weight and higher blood pressure in later life. And this is not limited to the adult population. It's across age groups. It's independent of body mass index. And the data is adjusted for lifestyle changes, sedentary lifestyle, dietary choices as well, and family history. So it's quite robust data. Unfortunately, blood pressure tracking can develop quite early in life. So in a study which looked at close to 2,000 infants, noted that you can track very confidently the blood pressure from 4 years of age. So it's important that we understand the mechanisms, and especially to adult cardiologists, to ask this question of their patients about the birth history. So unless we understand why this is happening, it would not be easy for us to address the high prevalence of hypertension in the adult age group. Two additional mechanisms which are especially relevant to adult health, but they start in the early neonatal pediatric age group, is catch-up growth, which means that if there is in utero undernutrition and followed by rapid catch-up growth during childhood, that has a double hit, so to say. For example, the mean 24-hour ambulatory BP was higher in adolescents who had low birth weight in combination with later obesity compared to normal birth weight or those low birth weight without obesity. So these two factors are, if both these factors are present in an individual, then it really puts them at a very high risk. And second is the thrifty phenotype hypothesis, where during fetal life, when there is an essential nutritional factor deficient, that leads to some crucial organs, especially the heart, as my focus today, the blood vessels, to maladapt. And that change seems to be quite permanent. It doesn't really go away with time. So let's talk about, start from before birth, fetal life, and focus on hypertension and arterial remodeling. So this study evaluated how relevant is fetal ultrasound to predict hypertension and arterial remodeling 6 months after these babies were born. So for this study purpose, infant hypertension was defined as mean BP more than 95th centile, and the thickness of the aorta intima media was taken as more than 75th centile at 6 months. And they looked at 100 consecutive growth-restricted babies and control fetuses who were observed well into infancy. So busy slide, but I'll break it into 4 parts. So this is univariate analysis looking at association between the fetal echocardiography parameters with the outcomes, namely being hypertension and arterial remodeling, ascertained at 6 months of age. So the standard perinatal parameters we look at, gestation age at delivery, you can say ductus venosus, pulsatility index. So they were not particularly significantly correlated with the outcome we were looking at. Certainly other parameters like uterine artery, PI, and pulsatility index when the umbilical arteries, those were relevant, but commonly thought ductus venosus abnormalities are pre-terminal, but for the outcome they were looking at, they weren't particularly statistically significant. When you look at the cardiac morphology and systolic diastolic function, you can see between the two, the systolic and diastolic function, it is the diastolic function which has a very strong univariate correlation with the outcome they are looking at. And not so much with ejection fraction, not so much with LV stroke volume, and not so much with left-sided cardiac output or so. So based on this study, they created a fetal score. It's a cardiovascular risk score, which when you do an echocardiogram in the fetus and do these measurements, then it is highly predictive of hypertension and arterial remodeling, which is going to come ascertained at about 6 months of age. So if you were someone who is designing interventions, or if you are someone who looks at resources in public health and you really want to focus on the IUGR population, the message to them from this study is that within the growth restricted cohort, there is a sub cohort which is at a higher risk with a high sensitivity of 90% or so to develop arterial remodeling or hypertension. So if resources were limited and you really wanted to focus on the highest of the highest risk groups, in this particular score on fetal ultrasound can help you discern that population to be acted upon. The other important thing is gestation and birth weight is not particularly associated in this study for occurrence of the outcomes, but it is the fetal echo diastolic parameters which are strongly. So if you are a perinatologist or an obstetrics ultrasound person, then it's important for you to focus on these particular parameters before these babies are born and give the information to the neonatal team. Look, this is the higher risk within this high risk category to be closely monitored postnatally. So from early fetal life, if we go a little bit further to 32 weeks gestation, and this study looked at, measured the same parameter, the aorta intima media thickness, and they compared, they looked at correlation between what happens in fetal life and then what happens in 18 months in the same cohort. So again, those that the cohort which had higher readings in the fetal life continue to have higher readings at 18 months. Systolic BP in these groups were higher, and it correlated with what you were able to see on the aorta. So there is a very important interlinking between the systemic arterial circulation and the blood pressure as a clinical outcome, and that starts very early, information coming from the fetal life as well. And this information can go on to 8 to 13 years cohorts, as well as young adults where they have increased stiffness, impedance, and higher central pulse pressure in the growth restricted population. So very early on, you have the ability to differentiate, and that can be identified before birth, that which is the cohort which is predisposed to later hypertension or cardiovascular disease risk. So from 32-week ultrasound, let's move to the placenta. Is there information from the placenta? This is some of our own work. We looked at preterm infants who were born growth restricted and compared with equal gestation AGA babies. And we sent the placenta interstate for testing by a histopathologist who was masked to the identity of the cohort. And predefined characteristics were tested, which is standard Amsterdam placental workshop group consensus statement. Changes such as maternal vascular malperfusion, fetal vascular malperfusion, accelerated villus maturation. So these are very typical vascular changes which have been seen. A specific placental histopathology may be present in FGR placentae, which gives you a clue that this is the effect of uteroplacental insufficiency, essentially providing you evidence of involvement of the vasculature histopathologically even before birth. So fetal ultrasound gave you some information, and the placenta, focused on the arterial circulation, also gives you some information. So in terms of postnatal ultrasound criteria, what is in use? So this table gives you different indices. Look at of course, the thickness of the aorta intima media, then the wall stiffness, impedance, systemic vascular resistance, compliance. So this is all well studied, well validated in the pediatric population, and this is what I've been using since about 2013. And if anybody wants to look into detail about these parameters and how to do it, then you can look at this paper from our group about the journey starts from the fetal life and through to adolescence. You can see these changes. So this is some of our earliest work in 2013, where we looked at two groups of babies. These are term infants with fetal growth restriction, otherwise asymptomatic. If they are born by normal delivery, they go home with the mother on the second day or third day. If they're born by C-section, maybe a couple of extra days, but asymptomatic. They're not admitted to the nursery for no reason. They go with the mother, never to be followed up, only turn up as adolescents if the GP is good enough to measure the blood pressure to find them hypertensive. So these are clinically asymptomatic infants. But even in this group, you can see the first group is the growth restricted cohort. Second group is the AGA cohort. You can see that the aorta intima media thickness, stiffness, impedance is significantly higher as compared to the infants who are term but AGA. If you look at the preterm population, it's important because these are the infants who get admitted to the nursery mainly for respiratory reasons. So we looked at these cohorts in the second postnatal week, 30-weeker population to start with. And you can see here the systolic blood pressure in the second week of life they're not in the hypertensive category, but you can see it is significantly higher as compared to the equally preterm but AGA group. When we do the ultrasound of the aorta, and I see Nick Evans in the audience, and Nick, I think, published a paper in the Lancet in 2005. And when I was doing my fellowship in neonatal cardiology at UCH, my supervisor there printed that piece of that paper and put it in front of me. That, look, what a wonderful work, and I hope you can work on it in years to go by. So I have Nick to thank for his seminal work in the Lancet. So preterm babies we looked at, and we measured their aorta intima media thickness, and you can see here the graphic is very similar to the term babies, and wall thickness to lumen ratio is very different in the FGR babies as compared to the AGA babies. When you look at dynamic parameters, again, the message is the same. The first group is the FGR cohort, then the AGA cohort. Third column is unadjusted differences, and the last one is gestation age adjusted data. Either which way you look at it, their vessels are thicker, stiffer, greater stress, less compliant, and less pulsatile as compared to the AGA cohort. Now, how does it look like in real time when actually you're doing the scan? So on the left top panel is the abdominal aorta of an AGA infant. So at the back, you can see the vertebral bodies. The aorta is here in the middle. This is the dorsal wall. That's the ventral wall. Thickness is measured here. Pulsatility is measured here. You can see it's really thin, pencil-like, and nicely pulsatile. But when you look at the video on the top right panel, you can see the vertebral bodies at the back. Both the ventral and dorsal walls of the aorta are extremely thick, bright, and echogenic. When you put an M mode through it, you can see at the bottom left panel, at the bottom of the screen is the QRS complex. So whenever the heart beats, the waveform is passed on into the aorta. You can see with every QRS complex, there is a pulse, which is there in the ventral wall of the aorta. But if you look at the top, the bottom right panel, QRS complex is here at the bottom. The whole of the aorta moves with respiration, but not with heartbeat. So I submit to the audience that these aortas are thick and stiff. They have undergone early vascular aging, and they're behaving like arteries of the aged in the neonatal period. Now, of course, it's one body. It's important for us to look at other vessels, and one of the common morbidities preterm FGR babies face is lung disease, BPD. And a lot of emphasis is on what is happening in the alveoli, airways, parenchyma. We really came to this question from the ultrasound perspective, and we looked at the pulmonary artery and the right ventricular indices in preterm FGR infants and compared with equally preterm but AG infants in the second week of life. And the ducts had spontaneously closed in these infants. So for those who are familiar with ultrasound, you can see here, this is a modified short axis view. You can see here labeled aorta, the right pulmonary artery is underneath that, and the left atria is here. And this is a color view. You can clearly see that the branching of the main pulmonary artery into the right and left here. So it's a color Doppler showing the right pulmonary artery, and CM mode tissue Doppler of the right pulmonary artery to have sharp edges. And the picture is exactly the same as what you saw in the aorta. So in the FGR infants who are preterm, the pulmonary artery is significantly thicker. Right pulmonary artery in inferior wall is significantly thicker as compared to the EAG infants. And when you look at the dynamic properties, significantly thicker, less pulsatile pulmonary arteries, significantly greater surrogate measures of pulmonary vascular resistance, significantly dilated right ventricle, poorly contractile right ventricle, and also significantly slow to contract. So essentially, even the right side of the heart and the circulation is affected in these cohorts. Now, once these infants are born and they need oxygen, what we generally do is we give them surfactant. So we were interested, this is a more recent 2020 work from internal Monash collaboration with Risha and Callum. And we just wanted to see whether their responsiveness to a very common neonatal intervention in terms of surfactant is different. So the first group is the FGR population, double the number of AGA population. It's comparable in all respects. Of course, the birth weight is lower and similar respiratory support requirements to begin with, similar pre-surfactant blood gases. So this table compares pre-surfactant echo parameters. So surfactant has not been given as yet. So again, these are preterm infants who are less like within the first day of life. You can see here the cardiac contractility in terms of the TAPC is lower, RV stroke volume is less, and there is equal proportion of right to left shunting on both sides. But when we give surfactant to these infants, comparing the first two echoes in the growth restricted babies, the first two columns, and then echo 1 in the AG and then echo 2 in the AG infants, you can see here that the change in echo parameters, so this is before surfactant and 30 minutes post giving surfactant through the catheter, the change in parameters is much less in the FGR cohorts as compared to the AGA cohort. So possibly in utero, in response to uteroplacental insufficiency, some changes have happened in the vasculature, which is leading to a dampening of changes in response to a common neonatal respiratory intervention. And this table tells you comparison of post-missed echo parameters. You can see here, this started off in a very similar fashion in terms of gestation, antenatal steroids, pre-missed blood gases and all, but the post-missed echo parameters are significantly different. So essentially more compromised and less adaptability to interventions which have been done to improve the respiratory outlook. This is a very recent work which came online just 2 days back. And we also wanted to see whether there are changes which tend to persist. So this is a cohort which has been given a dexamethasone as a DART regimen at about 4 to 5 weeks of life in terms of their chronic lung disease severity. So this is different from day 1 of life surfactant. This is day about 28 to 35, where we're giving dexamethasone, clinically indicated, decided by the medical team, and just wanted to see whether they respond to this intervention similar to what AG infants do and what happens to their heart. So performing an echocardiogram 24 hours before the start of the 10-day therapy and then within 24-48 hours after completion of therapy. So this panel looks at really the right-sided parameters in the main. Top left is the tricuspid annular plane systolic excursion, then bottom left is RV output, then top right is the surrogate of pulmonary vascular resistance, and then our bottom right is the LV output. So you can see here, this in the blue is the FGR echo 1, pink is the fetal growth restriction echo number 2, which is after DART regimen is complete. Green is the AG infants to start with, and the yellow is the AG infants at the end. As you can see here, even graphically, but I put the figures on the top, the change in different parameters is much more significant in the AGA cohort as compared to the FGR cohorts. They do improve. The FGR infants, so improved TAPC, improved RV output, but in terms of the magnitude of change or percentage change is much more significant in the AGA cohort. So there's something which is preventing this FGR cohort, even at about 4 to 5 weeks of age, to respond as well as we want them to be. The number of babies in the FGR cohort we managed to extubate was significantly less as compared to the AG infants, and the response in terms of the FiO2 or mean airway pressure also was much inferior as compared to the AG infants. So how do we assess arterial health? So we do ultrasound, so but other people can do pulse wave velocity measurements. This is more for pediatric and adult age groups. In adults, the carotid intima media thickness has been measured and changes evaluated over time. And very importantly, it has served as an endpoint in clinical trials when you're looking at intervention. In addition, arterial stiffness is a very strong predictive value for cardiovascular disease later on, uh, much more than the classical risk factors of high blood pressure or pulse pressure. So there is a message in these from this adult data that we need to look at this population and these parameters closely, because in adults, these parameters strongly predict future MI, stroke, or death related to cardiovascular disease. So this carotid IMT measurement is quite commonly used there. In pediatric population, the use is recent, and of course in newborn, because of the shortish neck, we don't particularly use that. But this is the only one study I could find where after 2 years of prevestin therapy here, the carotid intermedia thickness was used as an endpoint for this placebo-controlled RCT. Pulse wave velocity essentially measures how much time it takes for a particular pulse to go from carotid to femoral arteries. And of course, if it's faster, that means the arteries are thicker. And as I mentioned again, along with carotid intima media thickness, this pulse wave velocity has been used as a surrogate endpoint and is recognized by European Society of Cardiology guidelines as an excellent predictive parameter for future cardiovascular disease complications. Now, while it is important, it is also important to appreciate where birth weight fits into this. So birth weight inversely correlates with pulse wave velocity, making pulse wave velocity measurements as a reasonably doable diagnostic link between the two issues, which is low birth weight and elevated systolic BP. The question could be asked, what is going wrong in these cohorts antenatally, which is making these vessels so different? First, the elastin gets replaced with collagen. Collagen is helically organized, while elastin is longitudinally organized, is 100 times stiffer than elastin. So permanently tends to alter the compliance. And with normal aging, of course, you lose a lot of elastin. But if you're starting off with an elastin deficit, then this makes the FGR infants a classical cohort where you can study early vascular aging. A lot of things are started in utero. And as I mentioned, arterial stiffness tends to precede hypertension. So it's not a consequence of hypertension, but if you follow these cohorts closely, then you will see that arterial changes on pulse wave velocity tend to appear first before clinical hypertension is looked at. So along with the collagen elastin ratio, there are other changes like changes in the extracellular matrix, also impairment of endothelial function in these cohorts. That's very important. The other contributors, like importantly, the renin, angiotensin, aldosterone system, and also the sympathetic tone, inflammation, and oxidative stress. And unfortunately, the data which is cross-sectional as well as longitudinal tells you that the effect of these changes doesn't really go away after birth. While you are away from that hypoxemic, less nourished environment, these changes tend to be permanent in nature, and subsequently you see even in young adults, the arterial compliance stays low. Animal data in which we can do a lot of invasive studies can give you more information. This is data from Monash as well. FGR sheep models, FGR rat carotid arteries. The message is the same, that there is increased mechanical stiffness, there is increased diastolic BP, increased collagen, and increased wall thickness, and increased collagen to elastin ratio. So animal data, histopathology data corroborates what we see in human cases. Now, as I mentioned, the links are multiple. there is an important role to play by the reactive oxygen species and also the renin, angiostensin, aldosterone systems. The reason I mentioned these two is because these are of key therapeutic targets. Um, so as I mentioned earlier, that you can start figuring out the problems in these arteries in fetal life and also in the neonatal age group. We looked at preterm age group, 3 to 6 years, and also in young adults. And we are not the only ones who are looking at this issue. There's worldwide interest here, and you can see this slide summarizes the arterial effects of growth restriction in different age groups. In fetal life, I also mentioned the neonatal age group, but also you see in pediatrics there is increased carotid IMT at 3 to 6 years. Aortic elasticity, distensibility is compromised at 9 years. Aortic stiffness, impedance, 14 years, 15 years. Adulthood, increased resistance, decreased aortic diameter, and increase pulse wave velocity, and it just goes on. So as I'm just trying to stress that the changes you see in these cohorts are of relevance even if you're an adult physician. So it's important for adult physician, adult cardiologist, vascular biologist, public health people to understand that these changes just don't go away. So this is our pathophysiological model, which we published some time back, is how it all starts with uteroplacental insufficiency. And there is elastic degradation in the main. There is oxidative stress, sympathetic overactivity affects the aorta, impaired mechanics, and then it can cause back pressure changes to the heart, where there is increased systemic afterload. So there is increased myocardial workload, oxygen demand, cardiac hypertrophy, dilatation, and systolic diastolic dysfunction. Very important to appreciate these changes and their timelines. And whether it's endothelial dysfunction, whether it's smooth muscle collagen deposition, preventive strategies have to be put in place. They are likely to be beneficial when implemented early in life rather than once the disease is well established. And there is a lot of plasticity in the system to begin with. So people are looking at interventions in fetal life as well as early childhood. And the earlier you intervene, you have the potential or the possibility to change disease trajectory. And same interventions, if you put in place once the disease is established, then there is possibly inadequate response. So we are in a great position as neonatologists, perinatologists to look into what we can do, because pregnancy has become the new scientific frontier where there are prevention therapy possibilities aplenty. So I'll take maybe 5-10 more minutes to look at some therapeutic possibilities. So this is a study which was done by Michael Skilton from Sydney, looking at the relationship between birth weight and carotid intermediate thickness in children, and how it can be influenced with the help of docosahexaenoic acid-rich supplements from 6 months to 5 years, and also without supplementation, but increased dietary consumption could be helpful in terms of lowering BP and changing the thickness of the systemic arteries. Recently, the Spanish group has looked at breastfeeding and postnatal nutrition, tends to help in remodeling of the heart, and also tends to influence the arterial thickness going forward. So these are two interventions which have been looked and have been shown in the early studies to be good interventions. So improving nutrition, living conditions is key. Increased breast milk is key because of its metabolic benefits, and of course avoiding overweight, obesity to not have a catch-up hypothesis in these cases is very important. And as I mentioned earlier, some data about iron supplementation tends to modify the inverse association between birth weight and hypertension. So there is some information coming around that as well. So not a routine practice to have these implementations, but certainly breastfeeding and avoiding overweight obesity is something which is treatment of the obvious to to help these things. So monitoring childhood body weight is essential, especially for the cohorts which are born very young. Look at screening of blood pressure in infants and children who have significant perinatal history. As I mentioned earlier, fetal growth restriction per se is not included as a clear risk factor by cardiologists, pediatric cardiologists, or adult cardiologists, or adult physicians who look at these populations where blood pressure is an issue. So prevention is paramount, as the blood pressure of patients who had hypertension later on, who had lower birth weight, it may be difficult to control compared to essential hypertension without this risk factor. So often you might require multiple antihypertensive medications. And that goes to the point I've been trying to make all this while, is that there are some changes which have started in utero in terms of how the arteries are affected, which will make them resistant to easy hypertension control in these cohorts versus a cohort which was not low birth weight. That's the point. So prevention is important. I talked a little bit about breastfeeding and this intervention and the omega-3 polyunsaturated fatty acids. So I'll just skip that. But the message from work from Michael Skilton and the Spanish group is there are benefits related to breastfeeding and possibly higher dietary intake of the omega-3 PUFAs. Sildenafil was some time back proposed as something which could be useful because these cohorts with preeclampsia or FGR, they have less nitric oxide. So they could do with a vasodilator, which explains the rationale why sildenafil could be an option in pregnancy. Sildenafil decreases the activity of PDE5, so the cyclic GMP levels are better. There'll be better vascular relaxation. So RCT is looking at placebo versus sildenafil in FGR pregnancies. So while yes, pharmacologically makes sense, there is lower mean BP, improved uteroplacental resistance in the cohorts which got sildenafil, but in terms of neonatal outcomes of prolongation of pregnancy or better birth weight, that wasn't particularly effective. So yes, pharmacologically and physiologically sound, but outcome-wise, not yet. So perhaps we need some further refinement in terms of dosage and when we are intervening, we're intervening too late there, or you should just intervene a bit early and diagnose early. I mentioned a few times about the important role of the renin, angiotensin, aldosterone system. So high angiotensin 2 activity. So angiotensin 2 is the vasoconstrictor, proliferator, and angiotensin 1-7 is the exact opposite, vasodilator and anti-proliferator, you can call it. So essentially ACE inhibition can act in multiple ways by affecting the nitric oxide production, bradykinin levels, can affect the extracellular matrix as well, and also a range of other changes by aldosterone release as well. So this is something which is being looked at in great detail. And the reason why is that the RAAS has a very important impact on arterial structure and function, and important that ACE inhibitors can reset the balance between these proliferators and anti-proliferators and vasoconstrictors and vasodilators. ACE inhibitors have special properties which are not there in other antihypertensives like beta blockers or calcium channel blockers, because they not only reset the balance between angiotensin 2 and Ang 1-7, they also have an action on the vascular wall and also have an action on endothelial function. So it has been seen in different studies that ACE inhibitors, but not beta blockers, can cause regression of the media to lumen ratio. So essentially, it is remodeling the arterial wall, and this experimental research has been confirmed in clinical human studies where rather than increase BP alone, it's the change in the wall remodeling is what is relevant in terms of the outcomes we want to achieve. So ACE inhibitors may slow down, including A2 blockers, may slow down the vascular aging in these cohorts. So as I mentioned, the Ang2 and Ang1-7, these are counter-regulatory to each other. And this balance is very important to maintain if we can delay the progression of vascular aging and development of hypertension. So it's being looked at a very important therapeutic target. I bring the story back to before birth. So is there really biochemical evidence that this RASS system is relevant? So if you look at cord blood samples from FGR deliveries, they have high Ang2, possibly contributing to increased fetal placental vascular resistance. So these levels have been high during fetal life. And pregnancy, which are in addition to FGR being complicated with Doppler abnormalities, have further significantly high placental ACE levels compared to when Doppler abnormalities are not there. So as I mentioned earlier, in changes in placental pathology, vasculature, RAS activation really contributes to this remodeling. And the question really is, are there animal models in which of IUGR where we can use ACE inhibitions antenatally and look at vascular outcomes later on? This programming of the RAS doesn't go away after birth. So this tends to persist across lifespans. So compared to term deliveries, when you look at children or adolescents who were born low birth weight, their Ang2 concentrations are higher and their blood pressure is higher. So these positively correlate with the blood pressure going forward. I just want to spend next couple of minutes, last few slides, to this recent work which has come around from the Spanish collaborative group. And this, I think, is very, very important people understand this. This is a parallel group RCT of 1,200 individuals, singleton pregnancies, high risk of SGA. So they have given birth to a growth-restricted baby previously. And the group is divided into three parts. One is the Mediterranean diet group, which received some extra dietary educational sessions and free provisions of walnuts and olive oil. Second group is stress reduction group, where there are no dietary changes, but there is an 8-week stress reduction program. So like mind over matter. And the third group is the standard usual care group in a developed country. Primary endpoint is the percentage of newborns who were born less than 10 centile, and secondary endpoints are relevant to composite adverse perinatal outcomes like preeclampsia, mortality, low Apgar score, neonatal acidosis, all outcomes are relevant to a standard neonatologist. Now, this is the list of things they were advised in the first group, and also some assessment questionnaire is also in place to see the adherence to that. Of course, that's what you do in the RCT. But the point I'm trying to make is that if you look at these three cohorts, the SGA occurred in 88 newborns in the control group, 22%, while in the Mediterranean diet group, significantly less, 14%, and in the stress reduction group, 15.6%. So important that dietary interventions have a role to play. What you eat affects the fetus. In addition to that, even if dietary changes are not made, stress reduction itself is working to relax the mother and affecting fetal growth. So very important data. Secondary endpoints I spoke about, this is looking at 26.2 newborn to 26.2% in the control group, 18.6 and 19.5% in the stress reduction group. So very important data which tells you that after multivariate adjustments, the more you adhere with the recommendations of the Mediterranean style diet, lower the preeclampsia odds. So essentially, these are two interventions which have shown to be significantly reducing the percentage of newborns who are born less than 10th percentile. So take home message from this talk is that first important thing, subclinical cardiovascular disease begins early in life, perhaps in the fetal life, certainly long before clinical symptoms appear, decades later. There is a wealth of epidemiological data where low birth weight has been associated with increased risk of death from circulatory diseases. And very important for us to make arterial circulation the focus of our monitoring, prevention, and treatment strategies, and important to identify that this cohort needs to be followed well into adulthood, and adult physicians need to pay heed to perinatal risk factors, especially growth restriction, when we talk about risk factors which are contributing to diseases like hypertension and stroke.
Thanks, Arvind. That was a very a thorough overview of how cardiovascular changes appear, particularly with fetal growth restriction. You gave us information about the biological plausibility and the evidence behind it and how to measure it. Interestingly, there is measurements available to point out high risk infants, although they are generally not routine applied by the fetal maternal medicine specialist. Then you went into the neonatal phase, and what I personally feel is like, no, we growth restriction. Let's not get any complication. Get them to discharge alive and no neck, and then we're already sort of happy, isn't it? And then I guess for many of these are smallest of babies interacting not only with the pediatric group but even with the adult group becomes increasingly important as we have more and more information that preterm birth affects your whole life. You highlighted some fetal interventions, which are very interesting. Particularly, I love a Spanish diet and then a siesta. I think it could do good for everybody. So there definitely is going to be some questions on that. And you closed off again that how it's probably part of our task as neonatologists to reach out to the adult cardiology group and actually tell them about how preterm birth can be important, and we need to tell them that one of the questions should be not only do you smoke and do you sport, but were you born preterm and were you born growth restricted as part of their routine collection. Let's start with some questions which are already in the chat box, but also feel free to raise your hand and ask directly. The first question is about that when you mentioned and highlighted there's the possibility of ACE inhibitors as a treatment in fetal life. How far are we with that?
So yes, well, not close. We did submit. We did actually get a mini grant last year. So some work in the IUGR sheep is being done. Not enough though. But as I say, pharmacologically, physiologically, these cohorts are born with heightened RAS activity, which tends to persist during childhood and adolescence. And ACE inhibitors affect at multiple places. They, of course, reset the balance. They affect the tone. They affect the vascular architecture as well. The issue with postnatal interventions is going to come much, much later. As you know, not all of them are hypertensive to start with. I showed some data that their blood pressure is higher compared to equal gestation AGA babies, but they're not hypertensive. So to give ACE inhibitors to a newborn who's not hypertensive, that's going to be challenging. In addition to that we rarely give ACE inhibitors to infants who are even hypertensive, but less than 36, 38 weeks. So there are roadblocks in the neonatal area, but at least as a proof of concept, we should get some information from the sheep model. The other thing which I had to skip in the interest of time is the role of reactive oxygen species. So melatonin has been shown to be quite effective in the animal models in improving cardiac function as well as reducing pulmonary vascular resistance. So that's the other thing which Monash is looking at in human cohorts but their outcomes are more neurodevelopmental at 2 years and not cardiovascular, unfortunately. So that's a missed opportunity.
Thank you. Victoria asked, in that, latest Spanish study where they did stress reduction, what does that mean? You're muted.
I just, maybe I can go back to the detail of what exactly they were doing. So here is the Mediterranean diet issue. And so essentially this is adapted for pregnancy, weekly 2.5-hour sessions, 1 full day session. These are counseling sessions, these are yoga sessions, these are meditation sessions, and these are sessions where they teach them to relax and focus. So that's in a nutshell. But there's more detail if you look at the paper.
Anka asked, and something what I highlighted as well, now you find patients at risk. How can we inform the groups who are following them up, which was first will be the pediatrician and then GPs and then the adult physicians? What will be an educational strategy to inform them about this?
Informing the healthcare provider or informing the family?
Yeah, probably both, I guess. But what would you suggest?
So look, the follow-up, as I mentioned, if these cohorts are born at term, they go home with the mother. They're never followed up. So essentially, there has to be a chain in which starts with the obstetrician, which includes perinatologist, neonatologist, and they have to be pediatricians and GPs who have special interest in this particular line of thinking. And of course, in the discharge summary, we write in detail about the demographics and the anthropometric measurements. But the question is there knowledge and appreciation of to look at those parameters to say, oh, hang on, I got the discharge summary. This baby is hypertensive. Can I just look at that to look for features? And there has to be someone outside this network who can make that chain. And I mean, we do some follow-up, but it's more focused on neurodevelopmental and the respiratory follow-up. So cardiovascular follow-up is missing simply because this disease for a long time stays asymptomatic. So they are not clinically hypertensive until adolescence, although their blood pressure is tracking higher, and that's the issue there.
No, I agree with you. And we can take an example from the Northern European healthcare systems, which are much targeted on preventive medicine. So indeed, more follow-up to then prevent cases when they grow on to become an adult. So we have to reach out much higher than only GPs, pediatricians, and adult physicians. Sam, you have a question? Just unmute yourself.
Sorry. Okay, can you hear me?
Yes.
Right. Arvind, great talk. My question is, what is the role of sodium intake? In addition to the changes you had mentioned, which predict, systemic hypertension later on. Ruth Morley, I think nearly 20 years back, she studied the very low birth weight infant and looked at the salt intake, the sodium intake, and found the blood pressure of those who took higher sodium intake was higher compared to the lesser sodium intake during the first week of life.
Thank you, Sam. Good to hear from you again, and very, very important question. So the first paper I presented about the link between fetal growth restriction and hypertension in the offspring. So I really focused on the early vascular aging, but one of the areas we touched upon in that article was substrate and including especially sodium. So in addition to the salt intake, you see, if you work in the neonatal unit, half of the neonatal unit would be on sodium supplements because the sodium is between 130 and 135. And you go to a GP as an adult, as a walk-in, and you found to be hypertensive. The first thing they tell you is, salt restricted diet. And I ask my residents the question, why is the physician saying salt restricted diet? They say because they're worried about volume overload. I said, you're ambulatory, you walked, don't have any pedal edema. The issue with sodium is that it goes and sits in the arterial wall and makes the tone higher. So whatever the calcium is doing, sodium is an enabler for that. So really, salt restriction, or at least no added salt, is very important as a dietary modification if you really have to tackle. So avoiding obesity, avoiding catch-up growth, dietary modifications, sedentary lifestyle changes, and salt and diet. It has to be a multi-pronged approach to, if we really have to be anywhere close in addressing this major public health issue. So absolutely right, salt has a role to play.
There's
Thanks,
a follow-up
Arvind.
question here, which is related to that catch-up growth, which you mentioned, Arvind. If you have catch-up growth, would that make things worse?
Yes, definitely. So there is some data. Of course, if a baby is born small, as a parent, the idea is a bigger baby is a healthier baby, or like out of the woods kind of baby. But that's actually very, very wrong thinking. They need to follow their own centile chart. So if you compare three groups of cohorts, one is growth restricted, and second, so they follow their centile. Second is growth restricted to start with, and then crossing centile charts. So morbidity in terms of cardiovascular diseases later on is significantly higher in the second group. So growth restricted, so in utero nutritional deprivation, compounded by postnatal catch-up growth in terms of crossing centile charts, those two together is the highest risk group.
All right. Look, it's 2:03. This was a great session. Thank you all for attending and for the discussion afterwards. Arvind, thanks for presenting on this difficult but very interesting topic. And we hope to see you again next year for more sessions on this topic. And thank you all for attending. Next week, Adrian Gordon is going to talk about stillbirth and effects and what she found in her PhD studies about stillbirth. Hope to see you all next week. Thank you, Arvind. Thanks again.
Thank you, Kurt. Thank you.